Good morning. First of all, I'd like to thank the invitation to participate at this Congress. And I will speak about vaccine-induced immune thrombotic thrombocytopenia, VITT, which is a new entity, a new disease, and extremely rare as well. No conflicts to declare. And the first reports of VITT become from February 2021. And those reports were about thrombosis associated with vaccines which uses adenovirus as vector. That is, Oxford AstraZeneca vaccine from the UK and Johnson & Johnson vaccine from the USA. Here you can see that the incidence of VITT is quite rare, 2 per million vaccinated with the single dose of Johnson, 2 per million, and 1 per million vaccinated with AstraZeneca vaccine. And surprisingly, there are no reports of VITT with Sputnik or CanSino vaccines, which also use adenovirus as vector. So the largest number of VITT cases associated with those vaccines are from Europe and from the USA. You can see here the reporting rate per million vaccinated, 9.4 for AstraZeneca, 3.8 for Janssen. It's a few number, and most of the disease appeared after the first dose of AstraZeneca or after the single dose of Janssen. As the first reports were in health personnel, because the vaccines were distributed first on health personnel, most of the reports refers a prevalence in young people under 60s and in the female gender. Here you have the data in our country, in Argentina, in March, till March 2022, through the CONASEVA, that is in Spanish, Comisión Nacional de Seguridad en Vacunas. You can see two things in this slide. First, that the rate per million doses is very low, and second, that the association between the adverse effect and the vaccine is indeterminate. B1, here you have TTS, means thrombotic and thrombocytopenic syndrome, 8 cases category B1 and only 1 case category B2. It means that there is not a clear relationship between the vaccine and the disease. There is not a causal relation to be established in those cases. So what about the pathophysiology of this entity? It is quite similar to that of HIT, heparin-induced thrombocytopenia. It consists in an inappropriate immune response. Here you have on the surface of the platelet factor 4, a platelet agonist, which is a particle positively charged, will bind with the adenoviral vector in green, not the COVID, the adenoviral vector which encodes the spike of COVID, that is the glycoprotein S of COVID. The adenoviral vector is harmless for the human. So this complex triggers the production of IgG, and it forms an immune complex, PF4 polyanion, an antibody, which, let me see this, will bind the receptor on the surface of the platelet. The FC receptor R2A on the surface of the platelet. And this bond will determine two things. By one side, platelets will be captured by spleen macrophage, and consequently we will have thrombocytopenia. But on the other side, this bond with the receptor determines intracellular signaling, which produces platelet activation with aggregation, release of the contents of the granules and microparticles, and it means more PF4 and more P-selectin in the environment, and also it determines activation of monocytes and endothelial cells with tissue factor expression, and activation also of neutrophils with netosis. All of this drives to a procoagulant cellular response which ends in thrombosis. So this is the pathophysiology mechanism of the disease accepted till now. Well, this is the diagnostic pentade of VITT. We have the chronology, the vaccination 4 to 30 days previous to the beginning of the signs and symptoms, the thrombocytopenia, the documented thrombosis, and the presence in the lab of a D-dimer, high level of D-dimer, and the determination of antibodies anti-PF4 by enzyme immunoabsorbent assay, that is ELISA. That's the diagnostic pentade. What about the clinical manifestations of VITT? We have thrombocytopenia, thrombosis, the chronology already described. We have a high mortality, 20 to 60% in some series. Here you have all the signs and symptoms of the disease: headache, fever, visual disturbance, sickness, vomiting, seizures. It depends on the site of thrombosis. The thrombosis in many times affect unusual sites, especially cerebral venous sinuses and splanchnic thrombosis. Cerebral venous sinuses and splanchnic thrombosis, you can see there a portal vein thrombosis, or can affect hepatic, splenic, suprarenal, and so on. We can also have DVT and PE and arterial thrombosis, as you can see in the slide. And in the lab, we will have thrombocytopenia, high levels of D-dimer, and fibrinogen, low or normal. In the next slide, you will have, I'm sorry, but it doesn't work. Okay. Here you have the cerebral vein thrombosis, which is very frequent in this rare disease, and in 30% of the cases, it can provoke hemorrhagic transformation. In 30% of the cases. Here you have the signs and symptoms of patients with cerebral vein thrombosis. The most common symptom is headache, intense and persistent headache. So, as I don't have enough time, simply is to show you the site of, depending or regarding the site of thrombosis, you will have the typical presenting signs and symptoms in the second column, and in the third column you will see the diagnostic imaging to certify the thrombosis. Okay. It doesn't work. No, this way need.
I can help you. You have to put over there.
Okay. I tengo que apuntar. Thank you, excuse me. Well, the middle value of platelets is 20,000. We already said that in first report it was more frequent under 55 or 60 years and in the female gender. And the most important thing in this slide is that the risk factors for this disease are unknown. There is no increased risk in patients with previous thrombosis and no increased risk in patients with thrombophilia, inherited or acquired. So this is the diagnostic algorithm for patients suspected of VITT. When you have signs or symptoms concerning full thrombosis within 4 weeks from vaccination, if all the lab tests are normal, it is unlikely. On the other side, if you have only isolated thrombocytopenia, you have to consider another differential diagnostic, another mechanism immune for thrombocytopenia. But in the center of the algorithm, if you have clinical findings plus high levels of D-dimer and fibrinogen, low or normal, all of these accompanied by thrombocytopenia, you have to certify the thrombosis by one side and perform antibodies anti-PF4. Fortunately, at our country, we can determine it from January 2022, we have many labs that can determine antibodies anti-PF4 by ELISA for this disease. And finally, irrespective of the site of thrombosis, you have to hospitalize the patient and treat it with non-heparin drugs and with IgIV in high doses. Well, the diagnostic criteria of VITT, we already say it had to meet the 5 criteria. But we also can have in second place probable VITT when the D-dimer is high but one criterion is not met, or when D-dimer is between 2 and 4,000 or unknown and the other 4 criteria are met. We can also have possible VITT when the D-dimer is between 2 and 4,000 or unknown, and we have 1 or 2 only criteria not met. And VITT is unlikely if platelets are low but without thrombosis and with a D-dimer less than 2,000, or with thrombosis with normal platelets, D-dimer low regardless of any results of the antibodies, plus an alternative diagnosis more likely. So here you have the differential diagnostics of this disease. We already learned about them today and yesterday at the Congress. Most of them have thrombosis, thrombocytopenia, or an immune mechanism. Obviously, we have to differentiate from the thrombosis and thrombocytopenia of the infection from COVID. The heat, we have to differentiate because of the same pathophysiological mechanism, thrombotic thrombocytopenic purpura, immune thrombocytopenic purpura and Evans syndrome, antiphospholipid syndrome, especially the catastrophic one, atypical uremic hemolytic syndrome, and NPH. And about the treatment has 2 pillars that here you have the 2 pillars of the treatment, the control of immunity and the anticoagulation. The control of immunity when you have the clinical suspect of VITT, you don't have to wait the result of the antibodies. Immediately, if you have the availability of IgIB, you start treatment with high doses of IgMB. And concomitantly, anticoagulations, the WHO recommends, obviously, do not use heparins because of the same mechanism, physiopathological as HIT. And unfortunately, at our country, we only have DOACs to treat this disease. The most studies are anti-10A more than anti-2A, and especially rivaroxaban. And you have to take into account the risk of hemorrhagic brain injury in patients with cerebral venous thrombosis that in many situations that not contraindicate the anticoagulation, but you have to consensuate with the neurologist, obviously. And refractory VITT, in cases of refractory VITT or low level of platelets, you can use therapeutic plasma exchange as second-line treatment, corticoids, dexamethasone, there are case reports, or mechanical thrombectomy. There are some reports with other drugs in study, such as inhibitors of the tyrosine kinase, such as ibrutinib, acalabrutinib, because they inhibit the Fc receptor. And there are other studies with indomethasone and ticagrelor. Okay, so we only can use DOACs. And how long will be the treatment? Most of the authors agree with 3 months of treatment because it is a provoked thrombosis. And for venous thrombosis, we usually use the common doses for DVT or PE. You don't have to indicate platelet transfusions except for critical cases. There is no role for aspirin. And the prophylaxis with heparin, DOACs, aspirin in patients who will receive adenoviral vector vaccination is not recommended. So those here are the contraindications for these vaccines, especially when the patient presented previous HIT or VITT with first dose of AstraZeneca or with a single dose of Janssen. Here are, I'm not going to read all this because I don't have time. Those are questions still not answered about this young disease. For instance, and only the first one, why VITT does not appear in the original trials with adenovirus vector vaccines. In the right side at the top, you have the trial in Lancet when was published last year, the AstraZeneca vaccine. It was about 24,000 patients with AstraZeneca and no one developed VITT. It's weird, isn't it? And which is the one question is which vaccine do we are going to choose? The primary criterion for most authors for selection is availability, especially in underdeveloped countries like our country. In many situations, we don't have the possibility to choose the vaccine. So this is the primary criterion for selection. And you have to take into account that the efficacy and the adverse effects of the vaccine have not been compared in randomized trials. And in the end, to finish it, here you have tips on VITT, the take-home messages. It is an infrequent disease, but with high mortality. The efficacy of the vaccine widely outweighs the risk of VITT. In the UK, 1 dose of the vaccine reduces hospitalization and death by 80%, and in the USA, 2 doses reduce hospitalization by 94%. So the high frequency of thrombosis is with COVID infection, not with the vaccine. So always, 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 the immunization is preferred. Remains the immunization being the most important step to curb the pandemic. And to finish it, I would like to thank Dr. Cerecetto for lending me a lot of material to prepare this talk. I beg your pardon because I don't have a poem, neither in Spanish nor in English, but I would say a sentence that Dr. Cerecetto said, a phrase, during his EHA session last year about VITT. He said that in this story, the vaccine is not the bad guy, and I completely agree with him. So thank you very much for your attention.